So very good afternoon. Today we have a class on influence of systemic disorders on periodontium. The part 2 will consist of hemorrhagic disease and the part 3 is neutrophil abnormalities, which we have combined in one class. Okay, the learning outcomes would be that to point out the factors affecting hemostasis, describe the various lab tests which are advised for such a patient, outline the dental management of patients diagnosed with hemophilia. So this is pertaining to the hemorrhagic part. And next, coming on to the neutrophil disorders part, outline the role of neutrophils in the inflammation, list various neutrophil disorders affecting the periodontium, and discuss the common syndromes with neutrophil abnormalities that can have a periodontal manifestation. So, to start with, patients seeking dental care have medical conditions that may alter their course of their disease and the therapy provided. The therapeutic responsibility of the clinician includes identification of the patient's medical condition to formulate proper treatment plans. So, starting with hemorrhagic diseases, as you guys know, hemorrhagic tendencies occur when the normal hemostatic mechanisms are disturbed. So, clinical examination should detect the presence of jaundice, ecchymosis, spider telangiectasia, hemoarthrosis, petechiae, hemorrhagic vesicles, spontaneous gingival bleeding, and gingival hyperplasia, which tells about these hemorrhagic tendencies. Laboratory tests should also include measures to find out the hemostatic, coagulative, and the lytic phases of the clotting mechanism, depending on the clues regarding which phase is involved. So, mostly the hemorrhagic diseases includes the coagulation disorders, thrombocytopenic purpurias, non-thrombocytopenic purpurias, blood dyskaryosis, leukemia, and agranulocytosis. So now there are certain laboratory tests available for the bleeding disorders. So this is to be known by you guys because anytime and every time there would be a patient. Would be having some or the other bleeding disorders. So you'll have to know the normal, uh, uh, I mean, hemostatic test results. So to start with the vascular test, we can do the tourniquet test. If there are 10 petechiae, it's fine, but more than 10 petechiae, then it's considered to be abnormal. Bleeding time, normal is 1 to 6 minutes and abnormal more than 6 minutes. So next, coming on to the platelet count, know that it's 1,50,000 to 3 lakh is around normal. Anything less than that results in thrombocytopenia. And next, coming on to the coagulation, you have the extrinsic pathway, intrinsic pathway, and the common pathway. So to measure them, you have the prothrombin time, which measures the by means of the internationalized normalized ratio, which you will be discussing in the one of the slides, and the partial thromboplastin time, which measures the intrinsic and the common pathways, and the normal is around 25 to 40. Then coming out of the clotting time is around 30 to 40. So this is to be known by you guys. So whenever you have any vascular wall defect, try to rule out thrombocytopenia, purpurias, telangiectasia, aspirin or NSAID therapy, leukemia or renal dialysis. Thrombocytopenia, where the platelet count is less, then try to rule out any vascular wall defect, leukemias, liver disease, and renal dialysis patient. Starting with the coagulation disorders, you know that there are three coagulation disorders: hemophilia A, B, and von Willebrand's disease. Hemophilia A is the deficiency of factor 8. Hemophilia B, or the Christmas disease, is the deficiency of factor 9. And von Willebrand's disease results from the deficiency of the von Willebrand's factor, which mediates the adhesion of platelets to the injured vessel walls and is required for the primary hemostasis. It is prolonged in the case of partial partial thromboplastin time in hemophilia A and B, whereas in von Willebrand's disease, there is a prolonged bleeding time, PTT, and a variable factor 8 deficiency. So, generally, the clinician should consult the patient's physician before dental treatment to determine the risk of bleeding and the treatment modifications required. So, to prevent surgical hemorrhage, there should be at least 30% of factor 8 present in case of a hemophilia A patient, or 30 to 50 percentage of factor 9 present in case of a hemophilia B patient. So anything below this will result in more amount of surgical hemorrhage. So it has also been told that the desmopressin is one of the most important drugs which can be used to raise the factor 8 levels to twofold or threefold times in mild to moderate hemophiliac patients. Apart from that, you have the fresh frozen plasma, fresh blood, E-aminocaproic acid, tranexamic acids, and the factor 9 concentrates, which could be used to increase the factor 8 and the factor 9 levels appropriately. So next, coming on to the measures which you take in dental site, what can be done? Probing, scaling, and prophylaxis can be done without any medical modifications. Anti-hemostatic agents such as oxidized cellulose or purified bovine collagen may be placed over the sites. The antifibrinolytic agent, the E-aminocaproic acid, can be given orally or via IV as a potent inhibitor of initial clot dissolution. Tranexamic acid has been shown to prevent excessive oral hemorrhage after periodontal surgery and tooth extraction. Patients with severe hemophilia are usually treated in a dental based hospital setting. So, for them, hemophilia A, always a factor 8 replacement desmopressin is required. For hemophilia B, purified factor 9 products are required as a management measure. And for von Willebrand's disease, factor 8 replacement is required, and the same recommendation as that of hemophilia A management. So, this is in short for a dental management of a hemophiliac patient. Okay, the most common cause of abnormal coagulation may be drug therapy. These drugs are vitamin K antagonists that decrease the production of vitamin K dependent coagulation factors, that is 2, 7, 9, and 10. So, how do we find out for those patients who are taking these drugs? What do we do? We calculate the international normalized ratio, otherwise known as INR, where the patient's prothrombin time by the normal prothrombin time is calculated. And for such patients, we also see what procedures we are going through. So if we are going for infiltration anesthesia, scaling, and root planing, less than 3, then it is the less than 3 is also okay for uh, going in for the patient for that procedure. But block anesthesia, minor periodontal surgery, and simple extraction would require 2 to 2.5 INR. Complex procedures or multiple extraction would require at least 1.5 to 2 INR. Often the anticoagulant is discontinued for 2 to 3 days before the periodontal treatment, and the INR is checked on the day of the. Next, coming on to antiplatelet drugs, aspirin interferes with the normal platelet aggregation and can result in prolonged bleeding. The effects of aspirin last for at least 4 to 7 days, and this is usually given in small doses of 325 milligram. So, if the patient is taking more than 325 milligram of aspirin per day, then the drug has to be discontinued 7 to 10 days before the surgical therapy. Next, coming on to the influence of systemic disorders on periodontium, the neutrophil abnormalities. So, starting with what are neutrophils? They are the predominant leukocytes in the blood, accounting for around 2 to 3 2 thirds of the blood leukocytes. They possess many lysozymes within their cytoplasm, and the primary role of neutrophil is the destruction of the pathogen that threaten the tissues. They act as the primary defense cells. They also accomplish the neutrophil after finishing their work. They have to leave the cell, find again the target cells, and kill the target cells as well. This coming out of the role of inflammation, neutrophils in inflammation. So this may be a little difficult to understand, but this is a very important procedure which you have to understand why disease is occurring and how is the neutrophil helping in engulfment of the bacteria. So I've given you a YouTube link as well for you to understand it better and the timing period which you have to see to understand this better. So neutrophils, they go through these procedures called as migration, diapedesis, chemotaxis, phagocytosis, and oxidative burst. So what is this? We will be going through in the next slides. And for the exam, when a question on this is asked, you will have to write about all these 5 along with this diagram. So I will go on with explanation in the next slide. So starting with okay, starting with neutrophil invasion. So generally, when you have any damage in the body, in any part of the body, any damage, like it could be a physical damage or chemical damage or a bacterial invasion as well. So that is also a kind of damage, right? So there could be a neutrophil invasion which is taking place. So this is considered to be the hallmark of acute inflammation. So any damage which occurs. So in our case, you imagine that we have plaque which is stuck to the gingiva, and and during that time the bacteria is let out into the connective tissue. So that is happening in our case. So what happens is that neutrophils are generally present in the blood cells, in the bloodstream. So they keep on rolling. If you see the video well, you could have seen that the neutrophils keep on rolling all through the blood vessels. So once there's a damage to the cell wall by means of any form, like for example physical, chemical, or any bacterial invasion, what happens is that the blood flow slows down and a neutrophil starts to move to one side. So this is called as margination. So once it starts moving to one side, it tries to adhere to the endothelial cells which are present here. Once they adhere to the endothelial cells, the neutrophils stop rolling, and further adhesive interactions occurs with the cell because of the presence of two agents known as the E-selectin and P-selectin and ICAM1. So with this they get adhered. So once they are adhered, because of the cytoskeleton rearrangement, neutrophils try to escape out into the tissues through these gaps in between the cell, so by means of their cytoskeletal arrangement. So this is called as diapedesis, that is the escape of the neutrophils from the bloodstream into the tissues. So once they come outside, it means that the extravasation is complete. Okay, the same is explained here. As I told you, margination is the neutrophil adhering to the luminal surface of the endothelium. Diapedesis is how it migrates across the endothelium. And as I told you, the adherence is by means of two two integrants, that is the selectin, that is E-selectin, and the integrant, that is the ICAM1. So this again I will explain further, wherein you go in for neutrophil. Once they have come into the tissue space, they have seen or recognized the bacteria. So once they have recognized the bacteria, what they do is that bacteria as well as the neutrophil try to attract to each other. So they target the bacteria and they try to attract each other. So once the neutrophil is into the tissue space, they try to target the bacteria, and the bacteria also sends signals outside so that there is a attraction for the neutrophil towards the bacteria. So this process is called as the chemotaxis. Once this chemotaxis takes place, the neutrophil moves totally around the bacteria and tries to chase and kill it. How does it kill it? By means of engulfing the bacteria. This process is called as phagocytosis. So once the bacteria has come inside, there is a mechanism of reactive oxygen species mediated killing of bacteria through destroying the cell, by destroying the cell membrane of the bacteria. So this process is by means of oxidative burst. So as I told you again, chemotaxis is the directed movement of cell along the chemical gradient, and the neutrophil is attracted by the chemical signals sent from these bacteria. Opsonization refers to the process of coating a particle with a recognizable molecule to enable phagocytic ingestion. In the sense, the bacteria which is there, it has to be coated with a particular opsonant such as IC3B or IgG for it to be phagocytized. So, once phagocytosis takes place, it is mediated by both oxidative and non-oxidative mechanisms. So, oxidative mechanism includes based on the reduction of the oxygen with the resultant formation of toxic oxygen metabolites. So, oxidative antimicrobial effects are mediated by two main biochemical entities. One is the nicotinamide adenine dinucleotide phosphatase, another is the myeloperoxidase. So, how does the NADPH oxidase kill the microorganism? Is that it reduces the oxygen to superoxide anion or the hydrogen peroxide, thereby destroys the wall. Another substance is the hydrogen peroxide, which is also mildly toxic. So, in the presence of hydrogen peroxide, the MPO catalyzes the formation of highly destructive beach-like agent like hypochlorous acid, which is lethal to most of the microorganisms. Another killing mechanism is non-oxidative mechanism, where it is based on the membrane disruptive antibiotic activities of the peptides or the peptide domains within larger proteins. Next, coming on to neutrophil abnormalities associated with periodontal diseases. Again, this is also important. Please pay attention. Primary neutrophil abnormalities would be neutropenia, agranulocytosis, Chiari syndrome, lazy leukocyte syndrome, immunoglobulinemia, leukocyte adhesion deficiency, chronic granulomatous disease, specific granule disease deficiency. Secondary neutrophil abnormalities include Papillon-Lefevre syndrome and Down syndrome. So coming on to neutropenia, you know that as the term suggests, there are low levels of neutrophil present. An absolute count of 1500 cells per microliter is required. It could be a chronic or a cyclic one, and for it's in mild form, it is around 1000 to 1500 neutrophils present in the body in microliter of blood. Moderate 500 to 1000. If it is less than 500, then it may be a little life threatening. Next is agranulocytosis. There's reduction of the circulating granulocytes, results in severe infection, and less severe forms of this infection are called as neutropenia. Drug idiosyncrasy is the most common cause of agranulocytosis. Generally, it occurs as an acute disease. Ulceration in the oral cavity, oropharynx, and throat is characteristic. The absence of a notable inflammatory reaction caused by lack of granulocytes is a striking feature for agranulocytosis. Next, coming on to the Chiari syndrome. This affects the production of the organelles found in every cell. It affects mostly the melanocytes, platelets, and the phagocytes. Causes partial albinism, mild bleeding, and recurrent bacterial infections. Neutrophil contain abnormal giant lysosomes that can fuse with phagosome, but their ability to release their contents is impaired. As a result, the killing of the ingested microorganism is delayed. So, this has been found to occur in aggressive periodontitis patients. Lazy leukocyte syndrome, characterized by the susceptibility to severe microbial infections, neutropenia, defective chemotactic response by neutrophils, and an abnormal inflammatory response. Leukocyte adhesion deficiency, LD1 and LD2 diseases. They are very rare genetic disorders. Primary immunodeficiency is noted. It is the inability to produce or failure to express normally an important cell surface antigen called as the CD18 cell. Papillon-Lefevre syndrome, it's an inherited disorder, follows autosomal recessive pattern, and there are hyperkeratotic skin lesions, severe destruction of the periodontium. So the microscopic changes would include there is a marked chronic inflammation with plasma cell infiltrate, osteoclastic activity, and lack of osteoblastic activity. Bacterial flora studies of the plaque in a patient with Papillon-Lefevre syndrome revealed a similarity to the bacterial flora in chronic periodontitis. So Down syndrome, it is a congenital condition caused by chromosomal abnormality characterized by mental deficiency and growth retardation. Prevalence of periodontal disease in Down syndrome is generally high and is characterized by deep pockets with substantial plaque accumulation and is usually generalized. Acute necrotizing ulcerative lesions are common and there's a high prevalence and severity of periodontal destruction. In severe periodontal diseases, that are mainly aggressive periodontitis, it has been found that neutrophils are having defect because it possesses an intrinsic defect in phagocytosis and chemotaxis. Neutrophils may exhibit increased levels of O2 production and exhibit a selective decrease in the ability to kill the Accomitans bacteria. Leukemia, malignant neoplasms of the WBC precursor cells are called as leukemia. This may be characterized by following, where there's a diffuse replacement of the bone marrow cells with proliferating leukemic cells, abnormal numbers and forms of immature WBCs, widespread infiltrates in liver, spleen, lymph nodes, and other body sites. According to the cell type involved, leukocytes may be classified as lymphocytic or the myelogenic leukemias. So the periodontium in leukemic patients, the oral and the periodontal manifestations of leukemia may include leukemic infiltration, bleeding, oral ulceration, and infections. The expression of these signs is more common with acute and subacute forms. Leukemic infiltration, the cells can infiltrate the gingiva and less frequently even the alveolar bone. Leukemic gingival enlargement consists of basic infiltration of the gingival corium by leukemic cells that increases the gingival thickness and creates a gingival pocket. Thereby, bacterial plaque gets accumulated. Thereby, secondary infection occurs. The periodontal ligament and the alveolar bone may also be involved. The marrow of the alveolar bone exhibits a variety of changes such as localized areas of necrosis, thrombosis, infiltration with mature and immature leukocytes, and occasional RBCs and replacement of fatty bone marrow with fibrous tissues.